Welcome to the Advanced Renal Topics for Nurse Practitioners. I'm John Tsai from the Long Beach VA Medical Center and the University of California Irvine Medical School. Today we will continue our discussion on hyponatremia and how we assess volume status and the ADH state of the patient. We have already talked about ruling out pseudohyponatremia in the Part 1 video, so we will jump today straight into Step 2, which is determining the patient's volume status. By determining volume status, this can help us think about the current ADH state of the patient and the associated differential diagnosis based upon the volume and ADH state. Afterwards, we can tailor their therapy to the underlying diagnosis. In this presentation, we will assume that we are dealing with a true hyponatremia or hypoosmolar hyponatremia. Why do we think about the ADH state? ADH, or antidiuretic hormone, is the main hormone produced in the posterior pituitary gland that is responsible for water handling. As a reminder to your physiology lectures from before, ADH binds to the V2 receptor of the principal cell of the collecting duct as seen in this figure. In response to ADH, water channel molecules known as aquaporins get translocated to the luminal membrane. The translocation of the aquaporins then results in increased water reabsorption and prevents diuresis, hence the name antidiuretic hormone. In addition to ADH, it is also important to remember that aldosterone plays a large part in determining sodium levels. Aldosterone will bind to an intracellular receptor called the mineralocorticoid receptor. The resulting effect is an increased reabsorption of sodium molecules through the epithelial sodium channel, also known as the ENaC channel. To maintain electroneutrality, a potassium molecule is secreted for each sodium molecule that is reabsorbed. In low effective arterial blood volume states, or EABV for short, it is normal that both ADH and aldosterone secretion is high. The body naturally wants to retain sodium as well as water. So how does volume states help me assess hyponatremia? Well, volume status will help determine your ADH state, and if your ADH state is appropriate, then there's likely an underlying cause resulting in the hyponatremia that can be corrected. If the ADH state is inappropriate for the volume status, then you may have a case of inappropriate ADH stimulation, in which case the differential diagnosis narrows. Let's first think about hypovolemia, or volume depleted states. Examples of these are sepsis and severe blood loss leading to hypotension. In this case, the hypotension stimulates baroreceptors in the carotid body that signals our pituitary glands to produce more antidiuretic hormone and aldosterone. This is the first example of low effective arterial blood volume. But you may be wondering about all those patients in the hospital that you see who are hypotensive but don't have hyponatremia. Why don't septic patients who are always hypotensive and on pressors have hyponatremia if this is the case? Well, hyponatremia requires the addition or volume repletion of a hypotonic solution in addition to the high ADH state. Because your body wants to retain all that free water due to the high ADH state, your serum sodium will start to drop with any fluid that is relatively hypotonic compared to your serum. When we think of marathon runners who are routinely losing fluid throughout their run, they have a very high ADH and aldosterone state. Usually these people are drinking water and some Gatorade throughout their run, but both of these are relatively hypotonic solutions compared to the serum sodium concentration. Over time, the serum sodium starts to drop as they drink more and more of this hypotonic solution. Eventually, the runner can ultimately develop hyponatremia severe enough to cause seizures if they are not carefully and properly trained. In the case of hypervolemia, we typically think of three different diagnoses causing hypervolemic hyponatremia, which are heart failure, liver failure, and nephrosis. This nephrosis is the nephrotic syndrome and not necessarily kidney failure. If we think about the physiology in these states, we realize that due to poor cardiac output or splanchnic vasodilation in liver failure, or low albumin states, nephrotic syndrome, all of these essentially cause a decreased intravascular volume sensed by our baroreceptors, leading to what our body thinks is a low effective arterial blood volume, or low EABV. Again, because our body senses this low effective arterial blood volume, the ADH and aldosterone levels will be high. In the case where patients are drinking free water or hypotonic solutions, hyponatremia will inevitably develop. This is one of the reasons why fluid restriction is so important in patients with heart and liver failure. If we think about the urine sodium concentrations, or UNA, the low effective arterial blood volume stimulates aldosterone, and the high aldosterone will result in reabsorption of as much sodium as possible, resulting in low urine sodium levels. So in both cases of hypovolemic and hypervolemic hyponatremia, urine sodium levels should be low. Now let's tackle euvolemia. When we are at a normal volume state, our body typically does not secrete antidiuretic hormone, and so our ADH state should be low. In this case, urine sodium will usually vary depending on how much sodium is being consumed. If the ADH state is high when the patient is euvolemic, then there is likely something causing excess secretion of this hormone, otherwise called syndrome of inappropriate ADH secretion, aka SIADH. So why do we expect the urine sodium level to be here? Well, unlike our low EABV states, where our ADH state is high but urine sodium is low, our urine sodium SIADH is actually high. The reason for the high urine sodium is the interplay between the two major hormones, aldosterone and ADH. In this case, where ADH is being driven higher by an exogenous factor, and we are trying to reabsorb as much free water as possible, our aldosterone state is actually still low, meaning that there is no drive to reabsorb sodium. Our urine becomes concentrated with urine osmolality typically above 300, and our urine sodium levels are usually higher than 20. SIADH is usually a diagnosis of exclusion, and you'll want to exclude hypothyroidism and adrenal insufficiency that can cause euvolemic hyponatremia. How do we determine volume status? Well, the answer is actually a lot more difficult than most people think, and there's been a lot of intense focus on technologies to better estimate someone's volume status. Of course, we have our physical exam, and we can look for lower extremity edema, anasarca, pulmonary crackles, and we can also assess for jugular venous distension. In addition to our physical exam, we have our basic imaging modalities, such as chest x-rays that can show pulmonary vascular congestion or even pulmonary edema. Similarly, we can detect these on CT imaging as well. There are several non-invasive methods, such as bedside ultrasound or echocardiograms, to assess for a collapsible IVC or dilated atria or ventricles in the heart, which can be helpful in challenging circumstances. There are also newer technologies that some of you may be familiar with in the ICU or CCU, such as the Cheetah or Starling devices that use something called bioreactance to detect cardiac output. These bioreactance measurements are typically paired with a leg raise, which result in a quasi-fluid bolus to the patient to see if the cardiac output increases or not. And this ultimately helps determine if the patient is volume responsive. There are more invasive measures, such as Swan-Ganz catheters to assess pulmonary artery pressure and wedge pressures that can help determine someone's volume status. And more recently, there are devices such as a CardioMEMS device, as seen in the lower right here, that can be implanted in the pulmonary artery to measure someone's pressures. Swan-Ganz catheters have unfortunately fallen out of favor now and are being replaced by some of the more advanced non-invasive measurement techniques. But there are still some places that rely on these measurements to drive clinical management. So we have talked about different patterns of volume status in hyponatremic patients and what to expect in terms of their urine sodium concentrations. But sometimes we don't quite get the results that we want, as is typical in medicine. So what do we do in these situations, and what do these situations mean, and how do we deal with them? Remember that in a hypovolemic patient, we typically would expect a low urine sodium due to the high aldosterone and high ADH state. But what if the urine sodium is actually high? Aside from, of course, not getting your volume status correct, the reason for the high urine sodium in a hypovolemic patient is likely something has interfered with the natural biology of the kidney, specifically interfering with your sodium reabsorption. These typically include medications like diuretics, aldosterone deficiency or insensitivity, or renal tubular acidosis. Similarly, when we have our hypervolemic patient, we usually expect a low serum urine sodium because of their low effective arterial blood volume, leading to a high ADH and aldosterone state. If the urine studies show a high urine sodium, but the patient is known to be in heart or liver failure, then we again have to be thinking about things that interfere with the sodium reabsorption, the same things we mentioned before. Let's dive a little bit deeper into those things that can interfere with sodium reabsorption. Remember, it is the hormone aldosterone that attaches to the mineralocorticoid receptor, and activation of this receptor leads to translocation of the sodium ENaC channel to the luminal membrane, resulting in an increase in sodium reabsorption. So we can see that anything that interferes in this pathway can ultimately result in a decreased sodium reabsorption. First, you get aldosterone deficiency, which when you aren't producing enough aldosterone, like in adrenal insufficiency. Or you can get aldosterone insensitivity where the receptor is being blocked. This happens when we give an aldosterone antagonist, such as spironolactone or eplerenone. Secondly, if we block the sodium ENaC channel, then this will of course interfere with sodium reabsorption. This happens when we use medications such as amiloride or triamterene that specifically block this channel. Third, if we have too much sodium delivery that we overwhelm the ability of the sodium ENaC channel to reabsorb all the sodium, then we can get a higher urine sodium values than we expect. This is the case when we have other diuretics that affect the loop or distal tubule, or renal tubular acidosis that can result in distal sodium delivery. Lastly, how do we differentiate SIADH from normal states when we have euvolemic patients? Again, if the patient has low urine sodium concentration less than 20, this is expected as a patient wants to naturally expel the excess free water in the body. In this case, there is usually physiologic reasons for the low sodium concentration, either low salt intake or high water intake. The differential diagnosis here narrows to psychogenic polydipsia, beer potomania, and the tea and toast diet that we typically associate with hyponatremia. If the patient does have urine sodium levels greater than 20, this may be consistent with SIADH. But again, you want to rule out other causes of hyponatremia that look similar, which includes hypothyroidism and adrenal insufficiency. Hypothyroidism typically causes a decrease in cardiac output and an increase in ADH, but without volume overload. For adrenal insufficiency, the lack of cortisol stimulates ACTH production, which can also lead to persistent ADH secretion in the posterior pituitary. While SIADH is really a diagnosis of exclusion, it is actually very common, and many of the patients you will see in the hospital with hyponatremia end up having a diagnosis of SIADH. There are hundreds of associated causes of SIADH, but these usually can be classified into a couple of categories. Medications, especially psychiatric medications, are notorious for causing SIADH and hyponatremia due to their stimulation of ADH from the posterior pituitary. Any brain or lung pathology, such as malignancy or even infections, can cause SIADH as well. For those of you who work or will be working in the surgical departments, you may also commonly see uncontrolled pain, nausea, and vomiting postoperatively that can cause SIADH. Remember, it's not just the SIADH that causes hyponatremia. The patient also has to be given a hypotonic solution or free water to ultimately result in the hyponatremia. In summary, we discussed the difference in volume statuses and how the volume statuses will help us determine what the ADH state is in each patient. Remember that hyponatremia results from both a persistent ADH stimulation and provision of a hypotonic solution. I hope you can see that determining the volume status and ADH state can help narrow your differential diagnosis for hyponatremia. While urine sodium levels are helpful, sometimes they can reflect interference of sodium reabsorption, so I would caution all of you in relying too much on urine sodium levels that can lead to a wrong diagnosis. And finally, remember that SIADH is a common but still considered diagnosis of exclusion. So if you do diagnose somebody with SIADH, you will want to be thinking about the typical causes of SIADH, especially medications, brain and lung pathology, and postoperative pain, nausea, and vomiting that may be inducing a high state of ADH. That was a lot of material to cover, but let's do a question to see if you've grasped today's concepts. A 57-year-old gentleman with a history of heart failure is admitted to the hospital for volume overload and shortness of breath. His blood pressure is 107/64, heart rate 90, and pulse ox is 92% on 3 liters nasal cannula. Laboratory studies reveal a sodium of 125, potassium of 3.0, bicarb of 18, and a creatinine of 2.6. His urine sodium is less than 10. What is your next step in management? Is it A, fluid restriction? Is it B, salt tablets? Is it C, furosemide or Lasix? Or is it D, 3% sodium chloride solution, otherwise known as hypertonic saline? Go ahead and pause the video now if you need more time to answer the question. If you answered C, give furosemide or Lasix, congratulations, you are correct. In this case, the patient appears to be in decompensated heart failure, and he is clearly volume overloaded. The decompensated heart failure and volume overload would suggest that his ADH state in this case is high. Over time, if the patient does not have enough diuretics, the patient will develop hyponatremia with free water intake resulting in hyponatremia. The urine sodium being low is classic for heart failure and suggests that if he was prescribed diuretics, he actually wasn't taking them because if he were, his urine sodium would be high. To treat this patient, removing the excess fluid water with a diuretic will help bring him to a better part of the Starling curve and improve his cardiac output. Improving his cardiac output will then result in an improvement in the effective arterial blood volume and hopefully a switching off of the endogenous ADH production, which will also help to prevent further hyponatremia. The diuretic usually removes more water than salts, which will also improve the hyponatremia levels as well. That's it for today, but join us next time when we discuss the management of hyponatremia.